Dr. Manoj needs no introduction to this crowd, I believe. He's a very versatile ENT surgeon, taking every frontier of ENT, and no conference is there without his participation. I know Dr. Manoj for a very long time, and his area of interest is otology, and is a pioneering cochlear implant surgeon in the country, especially in Kerala. So we are very much eager to listen problem-based approach to cholesteatoma, which is the commonest problem we come across as ENT surgeons. I know that his wide experience will throw many doubts cleared to have a standard approach and treatment on this ever challenging problem of cholesteatoma. Over to Dr. Manoj.
Thank you, Raja. Thank you, chairpersons. Thank you, SZTNAOI, for coming back to the place where I did my schooling. So, like we all said, this is actually an enigma, and we all know that cholesteatoma is an aggressive disease. We know that there is a lot of chance of recurrence. The suffix oma, because it is like cancer, is not unduly given because it recurs often. There are a lot of challenges in post-operative care and management, and hearing rehabilitation in young children is a big issue because you don't want a young child to go to school with a 40-50 dB hearing loss. Now, one of the important things is to classify it properly. I know it's a very busy slide, but basically everybody who's dealing with cholesteatoma have to be familiar with the SAMI or ATO classification, where we also talk about what is the kind of mastectomy we do. Are we doing a very limited mastectomy? Are we doing a post-ectotomy? Do we remove the entire canal wall, or you just do an apicotomy? You go to whether the external canal is reconstructed, whether the mastoid is obliterated partly or fully. You also decide on what kind of ossiculoplasty is done, whether you completely retain the ossicular chain, whether you just have the incus, whether you do incus interposition, or you don't do anything at all. So all these have names there, and if you actually put them onto your research summaries, it will be great. Now the workhorse for all of us is the canal wall downplanoplasty. Now one of the recommendations that I tell people is that when you have a young child, it's important to do an end-on approach. Now when you have a patient with a cholesteatoma, and then in a young child, in an end-on approach is actually ideal for 2-3 reasons. One, there is less pain and it heals well, and the neoplasty is actually quite well shaped, because when you raise the flap itself, you are getting a nice cover for the mastoid floor. The only caveat would be there is a very large cavity, and that you would know before by imaging. So when you see a young child, small mastoid cavity, it is pertinent to do an end-on approach. And this is an art that is actually quite disappearing from ENT fraternity. I remember my teacher, Dr. Rabindran, who when he came from Delhi was an expert in end-on canaloplasties. I kind of learned it from him, but it's actually a great technique to deal with pediatric cholesteatoma, especially if the mastoid antrum is small. So you kind of do this, and then you can take out the tragus to the same attachment, you can put it there and graft it. If you want to, you can also take the temporal fascia from the same incision. So this is of a huge advantage in the young child. Now, if however you want to do it for a patient where you want to make the cavity smaller, this is the important thing that we face. All of us have cavity problems. Let's not kid ourselves. Cavity problems are present. So one of the things that you can do, especially teachers, when you train your youngsters, you can ask them to do a posterior tympanotomy in a cholesteatoma. It works in many ways. One, like Professor Mohan always says, the posterior tympanotomy is the surgical technique that you need to learn to do your ear surgery well. So they do a posterior tympanotomy and then take out the posterior canal wall. This canal wall can be used to obliterate the cavity by keeping it over bone pate and then grafting. This is an excellent technique where the whole posterior canal wall is now pushed back and done there, and it also trains somebody to do a posterior tympanotomy very well, which helps him or her to do cochlear implants, paragangliomas, vestibular schwannomas or later. But if there is a limited cholesteatoma, what do you do? Do you want to subject a patient with a limited cholesteatoma to a cavity? And this is the biggest dilemma that most surgeons face. Now, one of the things that you can do is, if you find this a very limited cholesteatoma, do a post-ectopenectomy and keep a gel form and push it through the post-ectopenectomy. What it does is that it will elevate the matrix out of the facial recess and sinus tympani. So once that is done, you can go through the canal and lift it off by keeping the gel form as a posterior margin. The treatment of cholesteatoma is so much like cancer surgery. So what you do is you have to come from beyond the disease. You don't go into the disease and operate. So when you do that and then you lift up the cavity from inside, you will actually find that when you are lifting it up, you are lifting it over the gel form that is being placed. And here it is of great importance, especially like in this particular case where the auditory canal is intact. So here you would find that when you are lifting it away, all the ossicles are intact, and then by keeping a cartilage beneath that, you can actually help the patient to have a nice cavity, good intact drum that doesn't retract anymore, because these drums are already bad. And in particular cases like this, with this patient who's got a cleft palate, you can also put in a grommet at the same time through the canal to prevent possible further retraction. Of course, you need to follow them up. I'll come to it later. So here what it is, so all that thing is there, the drum is kept apart, and then we will kind of move this a little bit forward, and you put in a grommet to the anterior wall. When you put in a grommet in a case like this, where you need a long-term control, where you expect the middle to repair itself and become normal later, always is a titanium grommet. Okay. Now, suppose there is no ossiculus here, what do you do? So here, you can do the classic combined approach to neoplasty. This is what you do, post-ectopenectomy. You have to do a malleus to foot plate interposition. It's not a great technique, see, because wherever there is no stapes and you put an ossicle or process or anything between the foot plate and the rest of the drum, you are never going to get good hearing. I mean, let's not kid ourselves. So if you want to get really good hearing in this case, either don't do anything at that point of time, leave it, and then go for a second stage surgery later. So here you are, the mid-ear is cleared, and then you are bagging the malleus of its attachment to the drum, put the cartilage there, then through the post-ectopenectomy, you can do the ossiculoplasty. And here it is important to remove the incus bridge there. So otherwise you won't be able to do the ossiculoplasty. Now there are a lot of caveats here which I will come to it later. Now what if there is advanced disease? Now here I generally would not like to do a post-ectopenectomy intercanal wall technique for an advanced disease unless I am certain this patient will come to us for follow-up. People that you know very well, your relatives, not a great area operating relatives, but doctors, their children, this is something that you can do. So what you would do is that you would actually take out the entire post-ectopenectomy, go right down to the tip, extend the post-ectopenectomy, make sure that you see the entire canal wall. And at all times, keep the posterior canal wall intact. It is often been said, especially if you go to Murph temporal bone dissection, Dr. Mohan always says that posterior canal wall is worth its weight in gold. It is actually true. So if you don't damage that wall, if you can do that, you can actually take away a lot of the disease from the middle ear, from the sinus tympani, and also be amenable for a second look surgery later. So here what we have done is that it's a post-ectopenectomy done. There is no reconstruction because there is no stapes. But on follow-up, 48 dB lost in 1 year, normal hearing in the other. Very few people would like to do a second stage surgery. So you just do a non-EPA DW imaging, which I will come to later. And once there is no disease, you can actually say that, okay, fine, we'll follow you up further. Now, oops. So here, sometimes when you think there is more extensive disease, what you would like to do, you would like to go inside, remove the disease and use an endoscope. And people who think that I don't do endoscopic ear surgery, of course I do endoscopic ear surgery, but this way after I've done my microscopy. So I use an endoscope, look inside there, and one of the things that I tend to use more and more these days, and for the last many years, that is, to use a KTP laser to lice away the adhesions of cholesteatoma to the ossicular chain, especially on the stapes. So here it's a large cholesteatoma, we are lifting it off the sinus tympani there, because we have to go very close to the patient now, extend the cholesteatoma approach, and after removing that, we shall go a little bit more. And after removing all the disease, we would, when the vitreous work is complete, we would actually look into it using an endoscope. That's all clean there, looks pristine. That's a round window, so use an endoscope, examine inside, and think that everything is good. But this is not the end of the story. Later, when I did the non-EPI DW imaging, there was cholesteatoma 2 years later. So let us not think too much of ourselves. However good you are as a surgeon, your eyes are never at that level, never microscopic. So you would actually, once you have done this approach, go inside, you will be shocked and stunned sometimes to see that you would have an epithelial burn which you may have to remove during a second surgery. So this possibility is something that you need to understand. However good your endoscope is, however good your camera is, you will never see it at the microscopic level. So here the case where you remove the epithelial burn and it was plasty later. So that's second look epithelial burn that we saw. See, the non-EPI DW technique is actually very sophisticated. It's not something that every radiologist can do. So what you need to do is that you need to train your radiologist to do it. It's not a very expensive technique, you don't need contrast. But if they do it very well, you can pick up cholesteatoma 1 millimeter. Now I am reasonably sure that we are, see, this is what you see on the CT. When you see something on the CT like this, the rest of the master completely good. I did the surgery myself in canal walk. The master looks brilliant. I see something here. And what could it be? Is it a mucosa? Is it a cartilage? No. Only the MRI will tell you if it's cholesteatoma or not. So CT is not a good thing. Now, one of the things that we always worry about is when there is a fistula of the lateral semicircular canal. We worry, we tell patients that, oh my God, you have a fistula, so when you do a surgery, you will become dead, you will not be able to hear later. But that's not entirely true. In fact, fistula is actually a good thing for many experienced otologists. If you have a fistula and the endoscopy is intact, the patient eventually lands up with good hearing. It is like the fenestration operation of Lampert, where the fistula communicates sound to the inner ear and thereby gives hearing. So here you have done this nice job, and then you would find out that there is actually improvement in hearing with the semicircular fistula.
A very interesting lecture, and you showed a lot of challenges what is happen during the surgery and how to prevent them also. One thing I like to ask you, you have highlighted the endoral approach that many surgeons are not doing that approach. I know that. In pediatric population, clinically we see very tiny attic perforation, but if you open up, you see wide extensive disease many times. You still handle them with the endoral approach.
So pediatric cholesteatoma I will always image. I told you already, we will always image. So a tiny attic perforation is no guarantee that you won't have an aggressive disease. It's always an extensive cholesteatoma. So if you have a small mastoid, I would tend to do endoral because that will give less pain to the patient. Post-operative suture removal is not needed. So overall the child feels better and more happier coming back to you because you need to see them year after year after year. The child has to feel good about coming to the hospital. And further the endoral. But remember, the endoral infection is a big complication of pericondylitis. So unless your theatre sterility is really high up there, it is not a great way to do it. But if you think your theatre sterility is good, ENT, the theatre sterility has to be on par with neurosurgery. If that is there, endoral is good. But like you said, I mentioned that if you have a very large cellular mass, which you can see sometimes in cholesteatoma, endoral will be slightly challenging. But you actually can do it by extending the incision a little bit backwards. You can go down to the mastoid tip. But ideally, an endoral approach is done in a small contracted mastoid.
And the second part of my question is, you insisted on the follow-up, and especially in question of surgery is very, very important, and I don't deny it. What is your trick in bringing your patients back to you for the follow-up?
I'm glad you asked that. See, what we do is that we have a register. So imagine that I am operating a patient today. The register is dated 8th of October 2025. So the register is made and the patient signs the register that they have to come for a second look or imaging or whatever at that time. Now we tell them that if they come at that time and have this thing, if we need to do a revision surgery, it is free. But if we don't come, it will be charged. So we called them up a month before, and we tell them that you have signed up this paper, you need to come back for investigation. Most of them come, they will complain, they will say there is nothing wrong with me, I am perfect, I am healing well. I said, they said, if something happens, I said, I can't guarantee, we have had failures, but you will have to pay the full cost of a full surgery. So that actually scares them a little bit, so I think that's why they come back to you.
It's a wonderful trick. So one more question, sir. You talked about pre-op investigation, imaging. Would you prefer CT or MRI?
See, cholesteatoma is a bone disease. So if you want to know what the cholesteatoma is and where you need to operate, you have to do CT only. I don't think MRI is going to help you anyway in that. MRI will not help you. MRI will help you if there is a complication. Imagine that the child has got, we want to know there's a brain abscess happening, if there is a sigmoid and thrombosis, all those things MRI is okay. So, Peter's epicytis, somebody presenting with lateral rectus palsy, then MRI is good. But if you are going to know how you want to approach your ear, if you want to do intercanal wall, what will be the ossicular change status, all the things the CT will show you in great detail. Follow-up, always MRI. I don't think a CT will show you anything at all. Because like I showed in the picture, the CT looked perfectly fine and I wouldn't, in fact my radiologist said that Dr. Manoj, it looks good. I said no. In fact, I don't know why they did the CT that I didn't order for a CT, I think the patient asked. But I said I needed a non-EPI and the non-EPI showed a prostate.
So when will you usually decide to do non-EPI?
In all these follow-up cases of cholesterol,
Time
2 years.
after 2 years.
2 years, after 2 years. Because by then it would have grown to about 1.52 millimeters. You don't want it to become too big. So if you do it at that time, you can go through the canal and probably remove it without not much of damage to the structures. You saw in the second look, most of the rest of the drum here looks normal. So that is when you need to remove the epithelial pearl. And epithelial pearl being a pearl, it can actually be teased away without much difficulty.
Any questions from the audience?
Sir, how often you encounter congenital cholesteatoma?
I showed you the series of 128, we had 4.
4.
It is not unusual, it's quite common. So it's not, I would say, not uncommon. But you need to keep that in mind when somebody with a ear complaint comes to you with a white looking drum. That is when you need to think about a congenital cholesteatoma. It is not unusual.
Many a times we see a lot of granulation around the stapes superstructure with the superstructure being eroded,
Yeah.
with the footplate not being visualized. So in such situations, what's your take?
That's again a good question. One of the things that you can do if you don't have a laser, I mean not everybody has a laser. So one of the things you can do is you can keep some gel form soaked in adrenaline there to decongest it. Sometimes that will decongest, that will allow removal easier. But I wouldn't go like gung-ho about it. I would sometimes leave it there and look what happens in second look surgery.
So sometimes the granulation is very thick and fibrotic.
Pardon?
Sometimes the granulation is very thick.
And fibrotic. Yeah, that is when I would not remove it because that would actually dislocate the stapes and be dangerous. So if you find too many granulations in the footplate area, my laser is very useful for that, the KTP laser. You can lyse it away. But if you don't have it, it will be best that you leave it for the second stage, which is actually quite good. That by the time you have healed the middle ear, when you go back and you would find clearly the difference between what was a disease and what is not. And many times when you go back, you will find that the granulation also disappeared because the disease was reversed. Thank you, sir.
Dr. Manoj, great presentation. See, 2 things that I usually find not being said during all these procedures which is very critical. One is about epitympanotomy, second is about mastoid tip amputation.
Yeah.
I believe that these 2 things are critical in preventing disease recurrence.
Yeah.
Second thing I wanted to ask about is in many cases, as you said, in some cases when the ossicles are involved, you used a KTP to shave off these things. We don't have the luxury of that. So many times we see the ossicles embedded in the disease. So usually, most of the time, we are not using it again. So is it pertinent in those cases that we remove the ossicles and then we are reshaping it? Any risk for any residual disease for you?
Great question, Sanjay. And because he's a very experienced otologist, I think these are very practical things. One, epitympanotomy is important, but I would tend to do in a child from the backside. When you do it through the canal, the problem is when you remove the antique from the middle ear side, your reconstruction is actually very challenging. I hope you know that. If you have a very large place of cartilage, we have found that in many cases that what looks good in 2 years doesn't look good in 4 years. We have found that epithelium is grow inside. but it is important, so you would actually remove much more than what you want to and use a much larger graft. If I were to do just an epidermoidectomy, for me I would put cartilage on both sides, which I omitted for the, sake of brevity in this talk. Master tip excision, absolutely important. We do it all the time. I should have included that in this talk. Master tip excision is a technique that you need to learn. You need to find out the digastric, and if you drill on the digastric and to the facial nerve, you can actually cut away the mastoid tip. That is one of the best things that you can do to make a mastoid cavity shorter. What you said is very important. See, this is something, a doubt that I always had. I think Irving Officials has got a large series of biopsy of bones taken from cholesteatoma. And he is actually demonstrated without any shadow of doubt that cholesteatoma does not go into bones. I don't know why that is there. It doesn't go inside the bone. So if you see a bone that is actually looking clean, if you can drill around it and polish it, it is probably safe. Now, that is why we tend to reuse bones. So if I find that there is a patient who doesn't have a staph, doesn't got only an incus, you can actually take the incus out, put it in a bottle and give it to them and ask them to keep it in the fridge. So that when they come for the revision, second look surgery, we use their own bone. This is something that I learned from Wolfsburg, where they do the same thing because that is actually good for the patient rather than using an allograft instead. Thank you.
Thank you, sir.